Hello everyone, greetings for the day. So I welcome you all for today's session on recall of questions asked during various competitive exams that was held recently, specifically our NEET PG 2025. I am Dr. S.Kanimozhi, Professor of Physiology and the Course Director for Physiology here at Dopamine. At the outset, I want to stress on this fact that if we look at these questions that have been asked, more than 75 to 80% of the questions that has been asked are the repeat questions that has been asked previously. And also another fact is, this repeat questions that has been asked, most of these questions have already been discussed by us during our NEET PG preparedness program phase 1 and phase 2. So with that note, let us go into our questions. So the first question we have here is a young patient experiences shortness of breath, specifically during exercise in winter months, which subsides after using salbutamol. What is the most likely explanation for this condition? So they've given us 4 options here. So before going into the options, let us again look at the key points in this clinical scenario. So we have a patient who is having shortness of breath. So this patient is having dyspnea, right? Okay, what is the second thing they are telling? Specifically when he is exercising during winter months. So there is dyspnea, which is exertional. That is during exercise, he has exertional dyspnea, and it is also seasonal. That is during winter months only this dyspnea is occurring. Another thing is relieved by salbutamol. Okay, so all these are key points. Dyspnea that is relieved by salbutamol and specifically occurs during winter months while the patient is exerting. Now they are asking what is the likely explanation for this condition. Now let us look at the options. So option A, what are they telling? Could it be due to vagal stimulation due to cold air exposure? Or is it due to decreased cardiac output that stimulates the baroreceptor? Or this condition is because of exercise-induced bronchoconstriction that is triggered by cold air? Or is it due to airway hyperreactivity due to cold-induced asthma exacerbation? So we have 4 options. Now let us rule out the options and see which is the right answer. So first option, what does it say? Vagal stimulation due to cold air exposure. Yes, definitely cold air exposure will cause vagal stimulation. Cold air exposure will definitely cause vagal stimulation. Okay, now vagal stimulation will cause bronchoconstriction. Definitely this is going to happen. But the bronchoconstriction which is happening because of this vagal stimulation will not be relieved by salbutamol. Okay, it's not going to be relieved by salbutamol. So what will be helpful in this scenario? An anticholinergic drug will be helpful. So that is why option A is not the right answer here. Let us look at the second option. Decreased cardiac output stimulating the baroreceptors. Definitely a decrease in cardiac output can cause exertional dyspnea. Okay, so already cardiac output is less. When the person is exerting, definitely he will present with dyspnea. But that again is not related to our explanation of relieved by salbutamol. That is also not going to be relieved by salbutamol, and it is not connected to this case scenario. That is very clear, right? Then most of the time confusion. So these 2 options automatically you would have ruled out as not the right answer. Now confusion will only arise between C and D. It could be either C or it could be either D. Now let us look at option D. Airway hyperreactivity due to cold-induced asthma exacerbation. Yes, this will definitely happen. Airway becomes hyperreactive because of cold, and that causes asthma exacerbation in susceptible individuals. Again, the pathway for this airway hyperreactivity due to cold induced is most of the time vagal mediated, and this will be unrelated to exertion, unrelated to exercise. That is, a patient who is already asthmatic, whenever there is a drop in temperature, will start coughing, will feel dyspneic, irrespective of whether he is exerting or he is not exerting. So that will be the case scenario if it is exercise-induced asthma. Okay, now look, so that is why this is also not the right option. Then we are left with option C. So obviously option C is going to be the right answer. But why? What is option C? Exercise-induced bronchoconstriction triggered by cold air. Exercise-induced bronchoconstriction that is triggered by cold air. So what happens here is, the patient is exerting. So whenever we are exerting, what will happen? The minute ventilation is going to be high. So there is heightened minute ventilation. When the minute ventilation is heightened, that means what? He is breathing in more air, right? So what type of air he is taking? He is taking cold, dry air. So cold, dry air is going through the airways. So when cold, dry air goes through the airways, what will happen? It makes the airway fluid hyperosmolar. Okay. So in this situation, the airway fluid becomes hyperosmolar. When the airway fluid becomes hyperosmolar, what will happen? The mast cell gets activated. The mast cell gets activated. Okay, so let me write it here. Cold air, cold dry air. Cold dry air will cause hyperosmolar airway fluid. It makes the airway fluid hyperosmolar because this cold dry air draws out the moisture from it, right? So because of this, airway fluid becomes hyperosmolar. When the airway fluid becomes hyperosmolar, it activates mast cell. Okay, and we all know when mast cell get activated, what does it release? It releases leukotrienes. It releases prostaglandins, right? And also histamine, key mediators of bronchoconstriction. So leukotrienes, prostaglandin, histamines, all this will be released and this causes bronchoconstriction. So that is why this bronchoconstriction on giving salbutamol, is getting released. So that is why option C is the right answer. Exercise-induced bronchoconstriction triggered by cold air. This is the correct answer for this question. I hope most of you would have got this answer right. Okay, now let us go to the second question. This is a very common question, right? If you look at your past question papers, always in any one of these competitive exams, one question definitely comes from this topic. That is the action potential curve. Both action potential curve of the nerve, action potential curve of the muscle. From both of these topics, questions keep repeating. So first, let us look at this question. What best describes the step 3 in this given action potential diagram? So they've given us an action potential diagram, and in this they are asking this step 3 or in this phase 3, what is the ionic change that is happening? Okay, and they've given us 4 options. So before going into the right answer, let us just briefly discuss the normal ionic basis of this action potential curve. So we have this action potential curve, and is this the action potential curve of a nerve, fiber, muscle, or an excitable, any other pacemaker cells? What is it? So look at the RMP. Resting membrane potential is around minus 70 millivolts. So it is the action potential of a neuron. Okay, so it is an action potential of a neuron or a nerve fiber. So now at minus 70 millivolt, the tissue is at its resting membrane potential, right? So number 5 is nothing but, so phase 5 is nothing but RMP, resting membrane potential, which is due to it is maintained by the sodium potassium ATPase pump. And one more thing, what helps in maintenance of this resting membrane potential? Yes, leaky potassium channels. So the leaky potassium channels, mainly the sodium potassium ATPase pump and the leaky potassium channels, helps to maintain the resting membrane potential of the neuron at minus 70 millivolt. That is the phase 5. Then what happens? At phase 1, what do you see at this one? One is nothing but the stimulus. So when you give a stimulus, what is going to happen? What could be the stimulus in case of this neuron? Either a release of a neurotransmitter or activation of a receptor. Anything could be a stimulus. So when a stimulus arrives to this neuron, what happens? There will be change in the membrane potential. Normally, how is it? The inside of the nerve fiber is more negative compared to the outside, right? Now, when you give a stimulus, the reversal of this charges are going to happen. So what is happening when you give a stimulus, and if the stimulus is adequate, then what will happen? It reaches the threshold of minus 55 millivolt. So when we give an adequate stimulus which reaches the threshold of minus 55 millivolt, then what will happen? An action potential is generated. Suppose if the stimulus is inadequate, then what happens? It leads to failed initiations. If the stimulus is inadequate, that means if it doesn't reach this minus 55 millivolt, then no action potential will be generated. That is what is seen as failed initiations. Okay. Now, okay, we have given an adequate stimulus and it reaches the threshold of minus 55 millivolt. Once it reaches the threshold potential, then what happens? We are going to a phase 2. Okay, that is nothing but depolarization. What do we call it as depolarization? So, number 1 is stimulus. Then, number 2 here is depolarization, right? Depolarization is due to what? Opening of voltage gated sodium channels. Because of this opening up of voltage gated sodium channels, can you see here? The sodium ion enters into the cell. Okay, so because of this sodium ion enters into the cell, that means sodium influx. Please be very clear with these terms. So during depolarization, what happens? As the cell reaches the threshold potential, the Hodgkin cycle happens, right? It's an example of positive feedback cycle. So opening up a few voltage gated sodium channel will open further more sodium channels. So this is also called as the Hodgkin cycle, which is an example of positive feedback mechanism. Okay, now coming back to our topic. So what happens? Voltage gated sodium channel open, influx of sodium ion. When sodium ion enters into the cell, now what is going to happen? From minus 55, the inside of the cell is going to become now more positive. Positive ions are coming inside the cell. So the membrane potential changes from minus 55. It reaches up to plus 35 to plus 40 millivolt. That is the peak of the action potential. And this is called as depolarization. Okay. Then at the peak, what is happening? Once it reaches the potential of around 40 plus 40 millivolt, then what is happening? Voltage gated sodium channel closes, and then we are going to the phase 3. That is what was asked in your question, right? Phase 3 denotes what? So in phase 3, what is happening? Two things. One is closure of this voltage gated sodium channels. Voltage gated sodium channels close, and then what happens? Opening of voltage gated potassium channels. So now when this voltage gated potassium channel opens, please look, potassium ions are leaving the cell. Because of the opening of voltage gated potassium channels, there is potassium efflux. There is potassium efflux, right? So during phase 3, what is happening? Efflux of potassium. Okay, so now what is happening? The membrane potential, which went to around 40 millivolt, because of the efflux of potassium, gradually keeps dropping down and reaches its resting membrane potential. Since these potassium channels are slow to close, they take longer time to close. Now what is happening? It goes beyond its resting membrane potential. That is, even after reaching minus 70 millivolt, still further efflux of potassium keeps happening. Further efflux of potassium keeps happening, resulting in this phase 4, which is also called as hyperpolarization. Okay. Hyperpolarization is because of continued potassium efflux. Okay. And this continued potassium efflux will take the membrane potential to almost minus 80 to minus 90 millivolt, following which the sodium potassium ATPase pump and leaky potassium channel will bring it back to its resting membrane potential, that is phase 5. Okay, so now I hope it is very clear, because this is very, very important that you know this. Without knowing this, you cannot go and sit for your PG competitive exam. Action potential graph, the ionic basis is very, very important, both for your nerve muscle as well as in case of your cardiac muscle. In both the cases, it is very, very cardiac muscle, smooth muscle, neuron. For all these three, the action potential graph is very important. They can ask you any questions. That is why we had a detailed discussion now in this. With this knowledge, let us go back and now tell me, this phase 3 is because of what? Yes, very good. Option is potassium efflux. Sodium influx means what? That is phase 2. Sodium efflux, it doesn't happen. Resting membrane potential is because of Resting membrane potential is phase 4, right? So this is what is phase 3. Okay, now let us go on to the next question, a similar question, right? At which phase of the cardiac action potential does amiodarone exert its primary effect? So here we have an antiarrhythmic drug, and what they are asking is in which phase of the cardiac muscle action potential this antiarrhythmic drug is acting. Okay, again let us look at what you see here is your cardiac muscle action potential. To be more specific, what is it? Ventricular muscle action potential. This is the ventricular muscle action potential. We also have another action potential which is also called as pacemaker potential, which happens in the excitable tissues like SA node, AV node, okay, which has the capability of autorhythmicity. So that potential is different, this is different. Okay, so this is a typical ventricular muscle action potential. So similar to our neuron, this also has different phases. So we have phase 4, then phase 0, 1, 2, 3 and 4. So let us start with phase 0. What is this phase 0? Phase 0 is also called as, let me write it here. So we have first is phase 0. What is this phase 0? Depolarization. Okay, so phase 0 is depolarization, and what is the cause of this phase 0? Opening up of voltage gated sodium channels and influx of sodium. Okay, sodium influx. See, always depolarization is due to sodium influx. So here in case of your cardiac muscle, here depolarization is due to influx of sodium ion. Sodium enters into the cell. Now we have different classes of antiarrhythmic agents. So certain group of antiarrhythmic drugs act at this phase. Okay, so those are sodium channel blockers. The drugs which is acting at phase 0 of the cardiac muscle action potential are called as class 1 or also known as sodium channel blockers. So they are going to block this sodium channel. They are going to act here and it is going to block the sodium channel. Example of such drugs are quinidine, procainamide, lignocaine. Okay, so all these are agents which act as the phase 0 of the cardiac muscle action potential. What do? They block the sodium channels. Now, by blocking the sodium channels, what physiological effect does it bring? Basically, what it is doing, it is decreasing the height and rise of this depolarization. By blocking, actually what it is doing, it is reducing the rise of depolarization. Okay, so when the depolarization is not rising sufficiently, then what will happen? It is slowing the conduction. Okay, it is slowing the conduction of the action potential. So this time they have asked about which phase the drug is acting. So next time they can also ask about what is the physiological effect that this particular drug is bringing upon by acting at that different portion. So you should also know this, right? So any drug which acts on the phase 0, that is any drug which blocks the sodium channel, will bring its effect by decreasing the rise of the depolarization. That means it is slowing the conduction. So that is for phase 0, that is depolarization. Following depolarization, we have phase 1. So what is this phase 1? Initial rapid repolarization. Phase 1 is initial rapid repolarization. What is the cause for this phase 1? It is predominantly efflux of potassium. Okay, it is predominantly the efflux of potassium that causes this opening up of transient potassium channels. Transient potassium channels are opening. Since transient potassium channels are opening, what is happening? Potassium is leaving the cell. Potassium efflux. That is the reason for the phase 1. And we don't have any known drugs that is acting on phase 1. No, any known cardiac arrhythmic agents that is acting on this phase 1 of the cardiac muscle action potential. Following phase 1, what do you have? Phase 2. So what is this phase 2? Phase 2 is also called as plateau phase. Okay, so phase 2 is the plateau phase. Here what is happening? It is mainly due to opening up of L-type calcium channels. So phase 2 is because of opening up of L-type calcium channels. Because of this opening of L-type calcium channels, what is happening? Calcium ion is coming inside the cell. Okay, so for this it is potassium efflux. For phase 2 it is calcium influx. Okay, so here what is happening? Calcium ions are coming inside the cell. So when calcium ions enter into the cell, what it is going to do? It is going to facilitate the actin-myosin cross-bridge formation. So it helps in the cardiac muscle contractility. Now any drug acting here, so any drug which is acting here and blocking this calcium channels are called as calcium channel blockers. Okay, examples of such calcium channel blockers are verapamil, diltiazem. All these are examples of calcium channel blockers. Now, how do these drugs act? They block the calcium channels. By blocking the calcium channel, what physiological effect it is bringing? It is decreasing the cardiac contractility. So, it acts by decreasing the cardiac muscle contractility. That is the action for the drugs that is acting on the phase 2 or the plateau phase of the cardiac muscle action potential. So, following phase 2, what do you have next is phase 3. Okay, phase 3 is also called as final repolarization. Phase 3 is also called as final repolarization. So, during this phase 3, what is happening? Efflux of potassium ion. So, potassium ions is leaving the cell, efflux of potassium ion. So, any drug that is acting at this level is going to cause blockage of potassium channel. Those are called as potassium channel blocking agents. So, our question, what was the drug in our question? Amiodarone. So, amiodarone is an example of a potassium channel blocker. So, where does potassium, which phase of cardiac muscle action potential does potassium channel blocker act? It acts on the phase 3. Okay, now what it is doing? By blocking, so what is its physiological effect? By blocking the potassium channel, what it is doing? It is prolonging the repolarization. It is prolonging the repolarization. Okay, then finally we have phase 4. Okay, phase 4 is nothing but restoration to the resting membrane potential. Then we have another class of drugs. So in this phase 4 of the ventricular muscle action potential, we don't have any drugs acting on the phase 4 of the ventricular muscle action potential. However, we have another class of antiarrhythmic agents called as beta blockers, right? We know beta blockers, right? So these beta blockers also act, and see in this diagram it is marked as phase 4. But I am telling it is not acting here. Then which phase 4? It is acting at the phase 4 of the pacemaker cells. Okay, so we have the pacemaker cells like SA node. So if you take the action potential graph of the SA node, this will be the phase 4. Okay, so in this phase 4, this will be phase 4, this will be phase 0, this will be phase 3, right? So this is your pacemaker. What I am drawing here is your pacemaker potential. So in this phase 4, these beta blockers are the drugs which will act. So beta blockers act on the phase 4 of the SA nodal action potential. Okay, and what do? They are going to reduce the heart rate. What are they going to do? They will reduce the heart rate. Okay, so that is how beta blockers are acting, its physiological effect. So now I hope it is very clear about the different classes of drugs, what channels do they block, at which phase of action per cardiac muscle action potential they act, and what is the physiological effect they bring about. Okay, so any questions can be asked from any topic, not just the ionic basis. Any of the points we discuss can be asked as a question. Now with this knowledge, let us go back to the question. Now you tell me, at which phase of the cardiac action potential does amiodarone exert its primary effect? It is a potassium channel blocker. Okay, it's a potassium channel blocker, and potassium channel blockers acts as the phase 3 of the cardiac muscle action potential. Okay, clear all of you? You should also know, as we discussed in phase 1, 2 and 4, do we really have any drugs? If at all they have, what do they block and how do they bring about its effect? Going on to the next question. Which of the following changes is seen on JVP in atrial fibrillation? Very direct question, right? We have a patient with atrial fibrillation. In a patient with atrial fibrillation, what are the JVP changes that you can observe? That is the question. So before going into the option, let us just discuss briefly about the jugular venar pulse here. So what you see in this image is your JVP waveform. And what does JVP actually tell us? JVP is telling us the functioning of the right atrium during the cardiac cycle. So during cardiac cycle, what is happening in the right atrium? That is reflected in our JVP. To put it in simpler terms. So JVP waveforms have three positive waves. What are those positive waves in JVP? We have our A wave, we have a C wave, and we have our V wave. A, C and V wave. All these three are positive waves in JVP. And then we have the X descent and Y descent, which are the negative waves. First, let us see. Most of the times questions have been asked, what is the cause of this wave? Or in which phase of the cardiac cycle do these waves occur? Now this time they have asked us a clinical scenario where in atrial fibrillation what is happening to these waves. So first you have to know A wave. What is the reason for A wave? A wave is due to right atrial contraction. A wave is due to right atrial contraction. A for A. A wave, atrial contraction, and we know JVP is directly reflected from the right atrium, right? Okay. So A wave means atrial contraction. What about C wave? C wave, C stands for C. C wave is due to closure of the tricuspid valve. C wave is due to closure of the tricuspid valve. Remember C for C. C, close. Closure of what valve? Obviously on the right side, what valve do you have? You will have the tricuspid valve. Easy to remember. A wave is due to right atrial contraction. C wave is due to closure of tricuspid valve. Then V wave. Okay. V wave, remember, filling of the instead of F, remember it as V. Okay. V wave is due to filling up of the right atrium. Okay. V wave is filling up of the right atrium during ventricular systole. So when the ventricle is contracting, the tricuspid valve is closed, and during that time the atrium is getting filled. So that is represented by the V wave. Is it clear? A wave, atrial contraction. C wave, closure of the tricuspid valve, and V wave, filling up of the right atrium during the ventricular systole. So remember V for V. Ventricular systole. So during ventricular systole, the right atrium is getting filled. That is the cause for V wave. Is it clear? A, C and V wave. Then let us look at the two negative waves, X descent and Y descent. X descent is due to the relaxation of right atrium. Okay. X descent is mainly due to the, after atrium contracts, it will relax. So this X descent is mainly due to the relaxation of the right atrium. And because of this relaxation of the right atrium, the tricuspid valve will be slightly pulled into the ventricles. Okay. So that is our X descent. Now Y descent. What happens during Y descent here? Y descent is due to the opening up of the tricuspid valve, and the right atrium is getting from the right atrium, blood is getting filled into the ventricles. Okay, so when the Y descent is due to the opening up of the tricuspid valve, and blood from the right atrium goes into the right ventricle. That is our Y descent. Is it clear the reason, the causes for all these three waves? Again, in this, three positive waves, A, C and V, two negative waves, that is the X descent and the Y descent. Now let us look at some pathological waveforms. So what was our question? What happens in atrial fibrillation? So in atrial fibrillation, there is no contraction, no atrial contraction. Okay. So in atrial fibrillation, we don't have any atrial contraction. So obviously A waves will be absent. Okay. Then there are some scenarios where we can have large A waves. Okay. What are those pathological conditions in which we can have large A waves? In case of pulmonary artery hypertension, in case of pulmonary stenosis. In all these conditions, what is happening? Resistance is more. There is high resistance. Okay. So when the atrium contracts against a very high resistance, it produces large A waves. Okay. Rather than simply mugging up, just try to remember the concept. Why this is happening? When will a large A wave come? Whenever the atrium is contracting against a high resistance, the A wave is going to be larger. Okay. So what are those conditions where we can have high resistance? In case of pulmonary artery hypertension, pulmonary stenosis can result in high resistance, which causes large A waves. Okay. Then we also have Cannon A waves. Most of the question will be focused on A waves only. Okay. Cannon A waves. When can we have Cannon A waves? When the atrium is contracting against a closed tricuspid valve. Okay. When it is contracting against a closed tricuspid valve, then Cannon A waves are seen. What are all those conditions where such scenario happens? When there is a complete heart block, ventricular arrhythmias and ventricular ectopics. In all these conditions, we can have CAN and A waves. Okay, 3 pathological conditions pertaining to A wave itself. Absent A waves in atrial fibrillation, large A waves in case of high resistance scenario like pulmonary hypertension and pulmonary stenosis, CAN and A waves when there is closed tricuspid valve in those scenarios like complete heart block, ventricular arrhythmias and ventricular ectopics. So that is in relation to our A waves. When can we have large V waves? Whenever there is tricuspid regurgitation. So whenever the tricuspid valve is not properly functioning, what happens? It is not closing properly. There is tricuspid regurgitation. So when the ventricle contacts, blood will go into the atrium, leading to large V waves. Okay, and then we also have something called as Kussmaul's sign. Okay, Kussmaul's breathing is different, Kussmaul's sign is different. Okay, so here in Kussmaul's signs, when do you see Kussmaul's sign? In case of constrictive pericarditis. In patients of constrictive pericarditis, during inspiration the JVP rises. Okay, in patients with constrictive pericarditis, during inspiration the JVP increases, and this is called as Kussmaul's sign. Okay, so this completes our discussion on JVP. Now let us see. What is the answer here? In JVP, in a patient with atrial fibrillation, what is the right answer here? Absent A waves. Going on to the next question. Which vitamin deficiency can cause lactic acidosis? They are asking which vitamin deficiency causes lactic acidosis. Let us look at each of these vitamins, right? Niacin. Niacin is what vitamin? What is the deficiency of niacin results in what? Pellagra. Okay, deficiency of niacin results in pellagra. Okay, riboflavin, deficiency of riboflavin results in cheilitis and glossitis. Okay, pantothenic acid. Okay, deficiency of pantothenic acid is very, very rare. Why? Because the deficiency itself is rare. Why the deficiency of pantothenic acid is very rare? Because this vitamin is widely distributed in most of the food items that we consume. So, isolated pantothenic acid deficiency as such is rare. If at all it occurs, most of the time it is a neurological and GI disturbances. Then comes thiamine. Okay, so what happens to thiamine? Thiamine is very important for what? Thiamine acts as a cofactor or coenzyme for conversion of pyruvate to acetyl-CoA. For conversion of pyruvate to acetyl-CoA, you need something called as pyruvate dehydrogenase. And this thiamine acts as a cofactor for pyruvate dehydrogenase. Now, if thiamine is deficient, if pyruvate dehydrogenase is not there, then what will happen? This pyruvate will be converted to lactate. This pyruvate will be converted to lactate. Okay. And when this lactate accumulates, what will happen? It will lead to lactic acidosis. Okay. So now do you know the answer? Which vitamin deficiency causes lactic acidosis? It is thiamine deficiency that causes lactic acidosis. So niacin is also called as vitamin B3, right? Riboflavin, vitamin B2. Pantothenic acid, vitamin B5. Thiamine, vitamin B1. Next question. A 28-year-old woman with fatigable weakness. This is a very direct question. Fatigable weakness, ptosis, diplopia. Just with these three itself, you could have already come to a diagnosis, right? Improved with, and also another women, improved with rest and ice pack. What is the mechanism? First, you have to identify what is the disease condition. So, what is the disease condition we are talking about here? What is this? Myasthenia gravis, right? So, this is a case of myasthenia gravis. Now, they are asking what is the mechanism. Let us look at the options. Option A, presynaptic acetylcholine receptor blockade. Do you have acetylcholine receptor presynaptically? We don't have. This point itself is not correct. Next, autoantibodies against postsynaptic acetylcholine receptor. Obviously, this is the right answer. But before going to that, let us also look at the other options. Option C, destruction of presynaptic calcium channels. In what condition does presynaptic calcium channels get destroyed? What is the name of the condition? Lambert-Eaton syndrome. Okay, only in Lambert-Eaton syndrome the presynaptic calcium channels are closed, so that is also not the right answer. Okay, now autoantibody against postsynaptic calcium channels. Again, we don't have calcium channels postsynaptically. This line itself is not correct. Option A and D are not even appropriate statement. So confusion will arise between B and C, and it is very obvious in myasthenia gravis. The autoantibodies are produced against the acetylcholine receptors that are located postsynaptically. The point what you have to remember here is the ACH receptors are located postsynaptically and not presynaptically. Okay. Next, we have another question here. At which point of the sarcomere length tension curve is maximum active tension generated? So they have given us a curve here. What is this? This is basically length tension relationship curve, right? And they have marked different points. A, B, C and D has been marked in this length tension relationship curve, and they are asking at which point A, B, C or D maximum active tension is developed. Okay. So now first you have to know what is the meaning of this active tension. Okay. Active tension is the maximum tension that can be generated in that sarcomere. Okay, stretching within the physiological limits, what is the maximum tension that can be developed is called as active tension. Okay, now let us look, to understand that, first let us look at this better length tension relationship graph. So in the x-axis what do you have? In x-axis we have the length of the sarcomere. In the y-axis what do we have? The force or tension that is generated. Okay, so whenever a muscle is stimulated, right, it is going to contract. When it contracts, what will happen? It is going to develop force or tension. The question is, at which of this point in this graph maximum tension is developed? Okay, so the length of the sarcomere at which the maximum tension is developed is called as the optimal length or resting length. So this is also a very important point. Okay, optimal or resting length, both refers to the same thing. Please don't confuse. Sometimes students will think that resting length means when it is at rest. No, resting length or also known as optimal length is the length at which the sarcomere will develop maximum tension. Okay, will develop maximum tension. Now, why it is developing maximum tension at this length? Why only at this length it is developing maximum tension? Because it is at this length optimal actin-myosin interaction is happening. Can you see in this image here? Please see here in this image. This is the optimal, what is marked here is the optimal length. Okay, so at this optimal length only, you see this is the length of the sarcomere. Okay, it is not marked here. Here you can see. This is the length of the sarcomere. At this length of the sarcomere only, maximum 100% maximum tension is developed at this particular length of the sarcomere, and this length is called as the optimal length or resting length. Now, why at this particular length only maximum tension is developed? Because for tension to develop, what do you need? For isometric tension generation, what is the most important thing? Overlap between the actin and myosin filament. That is, interaction between the actin and myosin filaments have to happen. And maximum interaction between actin and myosin filament happens, maximum tension will be developed. And that is the length at which it happens. So now, only at this optimal length, the actin and myosin will interact maximally. That is why. So, maximum tension is developed due to maximum actin-myosin interaction. Okay. Now, if I have to give in numbers, what is that length? That length of the sarcomere is between 2 to 2.2 micron meter. Okay. So, the length of the sarcomere at which maximum tension developed will be around 2 to 2.2 micron meter. Okay. Now, if I'm stretching the muscle more, okay, if I'm stretching the sarcomere more than this 2 to 2.2 micron meter, then what will happen? Look at this point here. Okay, when I'm stretching it further, suppose let us take this is 2 micron meter. When I'm stretching it to 4 micron meter, then what is happening? Can you see here? This is the actin, this is the myosin. Actin gets pulled away. So when actin gets pulled away, what is happening? No overlap or cross-bridge cycling happens. So there is no interaction between actin and myosin. When they don't interact, what will happen? It will not generate any force. Now let us look at a scenario at this extreme end, where the length of the sarcomere is only around 0.5 micron meter. So when the sarcomere length is very small, then what happens? Can you see? In this only the actin is overlapping on another actin. One actin filament is going and sitting on top of the other actin filament. So the myosin filament has no scope for interaction with the actin filament. So here also no force or tension is generated. So when the sarcomere length is too less also, no force will be generated. So when the sarcomere length is too less, no force will be generated. When the sarcomere, no force or very little force will be generated. When the sarcomere length is too much also, same scenario, limited or no force will be generated. Only at the optimal length of around 2 micron meters, which is also known as the resting length, maximum tension will be generated, because only at this length maximum interaction between actin and myosin filaments happen. Maximum cross-bridge cycling happens here. Okay, so next time the question, instead of asking you to mark these places, they can ask you what is the reason behind it. So you should know the reason also. Okay, so now with that in mind, tell me at which point maximum tension is developed. Obviously it is point B. Okay. Okay, we have next question here. Pretty direct question. Which best describe neuroparaxia? Okay, so they are asking about classification of nerve injury. So here we have the Seddon's classification of nerve injuries. According to it, we have 3: neuroparaxia, axonomatosis and neurotmetasis. Okay, so 3 are there. In neuroparaxia, their question is what happens in neuroparaxia. So as you can see in this diagram, this is the axon and then we have the surrounding myelin sheath. Okay, so what happens in neuroparaxia? The axon is intact. It is only the myelin sheath that is disrupted. Okay, what will happen here? There will be no Wallerian regeneration here in case of neuroparaxia. Recovery, usually full recovery will happen within few days to few weeks. Next, coming to the second one, axonomatosis. Here can you see what is happening? The axon is damaged. Whereas the myelin sheath is still intact. So the axon is disrupted. That is why it is called as axonomatosis. Why? Because the axon is disrupted. The myelin sheath is still intact. Here Wallerian degeneration is happens and the regeneration is very, very slow. When we come to the last one, the advanced stage, that is neurotomesis, here what happens? Both complete transection, both the axon as well as the myelin sheath are damaged. Here no natural recovery is possible. Only surgical intervention has to bring back the function of neuron to a certain extent. Here also Wallerian degeneration is possible. Okay. Now with this in mind, let us look at this option. So which among the 4 options best describe neuroparaxia? Is it intact axon, damaged nerve sheath, or axon damaged, sheath intact, or option C, both axon and sheath damaged, or D, both axon and sheath intact but conduction lost? It is option A, intact axon but damaged nerve sheath. So here we have next question. Okay. So we have a 35-year-old man who wakes up after sleeping with his arm draped over a chair and complains of pain. Which of the following accurately describe the order of susceptibility of nerve fibers? Directly they have already asked you. the order of susceptibility of nerve fibers in the given condition. That is, what is the condition here? Compression neuropathy. Okay, so this patient has compression neuropathy. When will compression neuropathy occur? When there is pressure on the nerve. So he has slept with his arm draped over the chair, and that has caused the pressure. So in case of compression neuropathy, which of the fiber is the most susceptible to pressure? Just remember this one point. When we have three scenarios, which are the fiber that is most susceptible to hypoxia, most susceptible to pressure, most susceptible to local anesthetics, right? So now here they are asking us to pressure, most susceptible to pressure. Which one? Pressure is very easy to remember. A, B, C. That's all. A fiber will be most susceptible, followed by B, and the least susceptible will be type C nerve fibers. Okay, so here you can see, easy to remember. When we are talking about pressure, most susceptible is A, followed by B, followed by C. So what is the answer here? It is option B. Option B is the right answer here. Okay. Next question. In malignant hyperthermia, mutation in ryanodine receptor causes which ionic abnormality? So already they have given you, in malignant hyperthermia, there is ryanodine receptor mutation. Because of this mutation of ryanodine receptor, which ion channel abnormality? Even if you don't know this answer, the moment you remember ryanodine receptors, okay, because we would have heard of, where would have you heard about this ryanodine receptor? In your muscle contraction, right? So we know for muscle contraction which ion is important? Calcium. Even if you don't know the exact concept here, if you try to recollect and correlate from the things you know, you would be able to answer this question easily. Okay, now let us look here. What is malignant hyperthermia? It is a severe reaction. Some people are susceptible. Okay, when they are administered a certain anesthetic agent, immediately they go into this malignant hyperthermia, which is a severe reaction where there is sudden rise in body temperature along with muscle contraction, which can result to be fatal. Why certain individuals are susceptible to malignant hyperthermia on anesthetic administration? Because these people have mutations, single point mutation in their ryanodine receptor 1 gene. Because of this gene mutation only. Now what happens when this ryanodine receptor 1 gene is mutated? What happens on administration of anesthesia? They behave differently and they will start releasing calcium ion, because they are mutated genes, they are not normal genes. So they will release calcium. Now in response to the release of calcium, what will happen? Muscle contraction will happen. When the muscle contracts, what will happen? It will produce heat. So thermogenesis will happen. When thermogenesis happens, what happens? The temperature will rise. When the temperature rises, further abnormal release of calcium ions from the sarcoplasmic reticulum will happen. The stored calcium from the sarcoplasmic reticulum will be released, and this vicious cycle keeps on continuing. That is why this is again the mechanism. What happens here is a positive feedback loop between calcium release and thermogenesis. So next time they can ask you the physiological mechanism. So what is the physiological mechanism here? It is basically a positive feedback loop between the calcium ions and thermogenesis. More heat, more calcium, more muscle contraction. Again, the heat is going to increase further. So this vicious cycle keeps on repeating until it becomes fatal. Okay. So the answer here is, what is the answer? Option D, increased calcium release from the sarcoplasmic reticulum. In malignant hyperthermia, ryanodine receptor 1 gene mutation results in increased calcium release from the sarcoplasmic reticulum. Okay. Next. A woman from Delhi travels to Ladakh, develops breathlessness, headache and lightheadedness. What is the primary mechanism? Again, a very direct question. So this lady is traveling to Ladakh. Beautiful place, right? Yes. So when she is traveling to Ladakh, what is she developing? Breathlessness, headache, lightheadedness. Okay. All symptoms of high altitude cerebral edema. What is the primary mechanism here? Is it metabolic alkalosis, metabolic acidosis, respiratory alkalosis, or respiratory acidosis? Again, this is a direct answer. By now you would have all got it right. I'm sure all of you would have got it right. The answer is respiratory alkalosis. Why respiratory alkalosis? As the person is ascending up, What is happening in Ladakh? What is it? The air is thin. So there is hypoxic hypoxia. So what type of hypoxia? It is hypoxic hypoxia. So hypoxic hypoxia is going to cause, what will happen here? Increase in ventilation. Okay, so there is hyperventilation. It will stimulate hyperventilation. Whenever there is hyperventilation, carbon dioxide washout is happening. Decreased partial pressure of carbon dioxide. So this is going to result in increase in pH, that is alkalosis. And this, why this alkalosis is called as respiratory alkalosis? Because lung is the cause. Lung is the cause of this alkalosis, so we call it as respiratory alkalosis. Okay, now do you understand why in this patient traveling to high altitude there is respiratory alkalosis? Why this is the right answer? Okay, another point what I want to stress here is, sometimes they will ask, in respiratory alkalosis, what do you see? Hypocalcemic tetany. Respiratory alkalosis will result in hypocalcemic tetany. There are many questions again in hypocalcemic tetany. What type of pH abnormality happens? In that manner also questions have been asked. So why in respiratory alkalosis hypocalcemic tetany is happening? Because there is decrease in hydrogen ion concentration. Decrease in hydrogen ion concentration. Now what will happen? Albumin will bind. Okay, now this albumin will bind with calcium. So decreased free calcium concentration decreases, that is ionic calcium concentration decreases, leading to hypocalcemia. Okay, clear? So we have discussed two concepts here. What type of acid-base abnormality will happen in case of hypoxic hypoxia when a person is ascending to high altitude, and also as a result of that acid-base abnormality, how hypocalcemic tetany is a presenting symptom. Clear all of you? Okay. Now let us move on to the next question. In similar line, patient flying to Leh develops confusion and headache. So basically here the patient is, they are very clear. What is this patient having? High altitude cerebral edema. The patient has developed high altitude cerebral edema. Now they are asking, what is the cause of this? Is it because of hypoxia causing vasodilation, or is it because of hypoxia causing pulmonary vasoconstriction, or is it acidosis leading to vasodilation, or is it due to carbon dioxide causing vasoconstriction? Option C and D is already directly ruled out. Now confusion will arise between A and B. Both these options are true, sentences are true on their own. Hypoxia, okay, hypoxia will systemic and pulmonary. Hypoxia has different effects on systemic and pulmonary circulation. In systemic circulation, it causes vasodilation. Why it causes vasodilation? Because now the brain cells are devoid of, the neurons are devoid of oxygen. So to have more oxygen, supply, what it is doing, it is increasing the blood flow. Okay, so to have more oxygen, it causes in systemic circulation, it causes vasodilation, increases the blood flow. When the blood flow to the brain increases, what will happen? Increase in the intracranial pressure. Increase in intracranial pressure is seen as headache. Why? Because it will result in, increase in intracranial pressure will result in what? It is going to result in high altitude cerebral edema. Okay. Here we are calling it as high altitude cerebral edema because the reason is ascending to high altitude. So whenever ICP increases, there will be cerebral edema which is presenting as headache. Okay. So that is why, what is the answer for our question here? Hypoxia causing vasodilation. This is the right answer. Okay. What about the effect of hypoxia on pulmonary circulation? In pulmonary circulation, it causes vasoconstriction. So it behaves differently. Hypoxia behaves differently in case of pulmonary and systemic circulation. In pulmonary circulation, it causes vasoconstriction, which will result in high altitude pulmonary edema, HAPE. In systemic circulation, it causes vasodilation resulting in high altitude cerebral edema. Has the question been features of pulmonary edema, then you would have selected option B. Okay. So please don't confuse. In the lungs, Hypoxia causes vasoconstriction. In the rest of the body, hypoxia causes vasodilation. Okay, now another question from respiratory system. In pulmonary embolism, already they are telling in pulmonary embolism there is no blood flow. Where will the shift be seen? So they've given a graph. What is this graph? It is a graph showing the relationship between the partial alveolar partial pressure of oxygen and the alveolar partial pressure of carbon dioxide. Along with it, the different ventilation perfusion ratios are marked. Okay, so now they are asking at point A, B, C or D, in which among these four pulmonary embolism will fit in. That is what the question is. Now let us discuss the options here. First, let us look at normal scenario. In general, normally what happens, and then we will move on to the pathological conditions. So normally this is our lung. If you look at the ventilation and perfusion, ventilation perfusion is not perfectly matched in all over the lung. So in different segments of lung, there is always some mismatch. Okay, not all lung regions. This will be the apex. Okay, this will be the base. This will be the middle zone. Okay, so among all these three zones, the ventilation and perfusion do not exactly match. Okay, how do we know? Let us look at the ventilation perfusion ratio. And what does this ventilation perfusion ratio tell us? This V by Q ratio, what is the significance of this? What does this ventilation perfusion ratio actually tell us? It tells us about information about gas exchange. Okay, V by Q ratio gives us information about gas exchange. What is the normal V by Q ratio? The normal V by Q ratio is around 0.8, because the normal alveolar ventilation is around 4 liters per minute, and for perfusion we are taking the cardiac output, which is around 5 liters per minute. So when you take it, the normal is 0.8. So normal ventilation perfusion ratio is 0.8. That is, we call it, it is matched. Where can you find in a lung? Normally, where can you find this ventilation perfusion ratio? In the middle zone. So ideal ventilation perfusion ratio is seen in the middle zone of the lungs. Okay, now let us look at the apex of the lung. What is happening in the apex of the lung? Okay, due to gravity, what happens in the apex of the lung? There is more ventilation. The alveoli are all larger compared to perfusion. Okay, so in zone 1, that is in the apex of the lung, these alveolus are more compliant. Okay, since they are more compliant, that means what? The size of the alveoli is larger. So the ventilation is better compared to the perfusion. Okay, so when you have ventilation is better compared to the perfusion in case of the apex of the lung. So in such scenario, the ventilation perfusion ratio is high. The ventilation perfusion ratio is high in case of the apex of the lung. It is around normally 3.6. The ratio is around 3.6. Now let us look at the base of the lung. Again, due to the effect of gravity, now in the base of the lung, the size of the alveoli are smaller. They are less the size of the alveoli are smaller. Okay, they are less compliant. Since the size of the alveoli are smaller, the blood flow will be better here. Okay, now in such scenario, what is happening? The ventilation is less, perfusion is better. In this scenario, ventilation is less, perfusion is better. So the ventilation perfusion ratio reduces. Normally it is around 0.6. So in the base of the lung, the ventilation perfusion ratio normally is 0.6. In the middle zone, it is 0.8, and in the apex of the lung, it is 3.6. So if they ask you among these three numbers, which is the best ratio, ideal is a ratio of 0.8. Okay, so when you extrapolate the same and look at this graph here, that is why they have written normal V by Q ratio as 1. Okay, they have approximated it to 1, which is considered to be normal, which is at the middle zone of the lungs. This is in normal scenario. Due to the effect of gravity, the V by Q ratio is different. So one set of questions can be asked in this manner. Which portion of the lung? How is the V by Q ratio? Okay. Now coming to our scenario where they have given us a pathological condition like pulmonary embolism. So pulmonary embolism, what is happening? Okay, before going into that, so at the base of the lung, the type of ventilation what we have is called as wasted perfusion. Okay, this term can also be asked. So in the apex, what do you have? Wasted ventilation. Why we call it as wasted ventilation? Because lot of air is there in the alveoli, but enough blood flow is not there for gas exchange. So that is why we call it as wasted ventilation. Why here we are calling wasted perfusion? Because the blood flow is there, but enough air is not there for gas exchange. So that is why we call the base of the lung to be wasted perfusion. Any of this can come as an MCQ question. Now coming to pathological scenario. Okay, so let us look at our scenario. What is our scenario? What are they telling? In pulmonary embolism, what happens? In pulmonary embolism, there is no blood flow. Air will be there, but blood flow won't be there. So that is mimicking what? Wasted ventilation, right? Because the air is there, but there is no blood flow. Pulmonary emboli is going and obstructing the capillary, so there is no blood flow, but air is there, oxygen rich air is there. This scenario is mimicking wasted ventilation. Okay, wasted ventilation is usually seen at this portion of this graph. Okay, so pulmonary embolism will be marked at this portion. Okay, and additionally you can also see in case of wasted ventilation, lot of air is there, and we all know the inspired air is rich in oxygen and almost minimal or no carbon dioxide. Why? Because in inspired air there is hardly any carbon dioxide that is present. That is why if you see, this point is close to the partial pressure of inspired air. Whatever partial pressure of inspired air will be directly reflected at the as the partial pressure of alveolar air, because we are inspiring the same air and there is no blood flow for gas exchange, so oxygen is going to remain in the air. That is why it is around 150 millimeters of mercury here, and this will be almost zero for the partial pressure of carbon dioxide. So if you remember at least this point also, you could have easily marked the point as D when it comes to pulmonary embolism. Okay, so this portion is for normal lungs. Let us look at the top. Okay, in the top, physiological conditions like left to right shunt, okay, can be seen here, where we have, what is this? Wasted perfusion. Here it is, wasted ventilation. Okay, so wasted ventilation already physiologically what we can see is during right to left shunt. Pathologically, what are all the scenarios? When there is a foreign body obstruction, it can create a similar scenario. When there is pneumonia, okay, when there is atelectasis. So when there is foreign body obstruction, pneumonia, atelectasis, we will get a scenario similar to wasted perfusion. Okay. Now, I also want to discuss these numbers, why here it is 0 and why here it is infinity. Okay, so here what is this? V is ventilation, Q is for perfusion. So anything divided by 0. Here in case of pulmonary embolism, what is happening? There is no blood flow, so perfusion will be 0. Anything divided by 0 is infinity. Similarly, look here, ventilation by perfusion. Again, here it is, what is happening? Wasted perfusion. So there is no ventilation. 0 divided by anything is what? 0. That is why here it is 0, and at this point of the graph it is infinity. Is it clear, all of you? And suppose if they are asking you to mark the portion of the lung in this ventilation perfusion graph, where will you mark the apex of the lung? Apex of the lung will be marked here, and base of the lung will be marked here. So the base of the lung is represented at the left upper corner. Apex of the lung is represented at the right lower corner. Clear, all of you? So now that is why option D is the answer. I hope it is very clear here. One last point what I want to add here is, sometimes question can also be asked, which portion of the lung Mycobacterium tuberculosis the bacteria can thrive well? What is the answer? Yes, it is the apex of the lung. It is the apex of the lung where the TB bacteria can thrive and grow well. Why? Because here highly compliant, the size of the alveoli is large, more oxygen is available, and there is no perfusion, so no gas exchange is happening. The oxygen is all there, so the bacteria can thrive well. So this has almost covered all type of questions that can be asked from this topic. Now let us move on to the next question. Okay, now we are moving on to endocrinology. Blood glucose was raised 2 to 3 times and maintained. What happens to insulin? So they have given 4 options here. It's a very simple, you would have seen this diagram in all your standard textbooks. What are they asking about? They are asking about the response of rate of insulin secretion for blood glucose. When blood glucose level increases, what is the rate of insulin secretion? That is what the question is. Okay, now what they are telling is the blood glucose is raised 2 to 3 times and it is maintained at that level. How will the insulin behave? Okay, so look at this graph here. Let us name this as A and let us name this as B. First look at A here. The blue line represents glucose and the red line represents insulin. Okay, so blood glucose from around, so here you can see the blood glucose from around 4 to 6 millimoles, it is raised to almost from 4 millimoles per liter, the blood glucose is now raised to around between 12 to 14 millimoles per liter. So and it is maintained at, it is raised and it is maintained at the same level. So in response to the increase in blood glucose, how does the insulin behave? Oh, and please remember, glucose is the most potent stimulus for insulin secretion. Glucose is the most potent stimulus for insulin secretion. Now what is happening? Immediately in response, within few minutes, here in x-axis you can see the time. Okay, within few minutes of increase in blood glucose, what is happening? We can see there is a sharp rise in the insulin. Okay, so within few minutes of increase in glucose, there is a sharp rise in insulin. Within 2 to 3 minutes of increase in glucose, there is a sharp rise in insulin. Following which, after the rise in insulin, what is happening? As the glucose keeps remain elevated, the insulin secretion also is elevated and it remains stable at that level. Okay, so that means there is a biphasic. Now look at option B where you are only seeing the insulin. There is a biphasic insulin response. Okay, so this is the phase 1, immediate, within minutes. Okay, then you can see this is the phase 2, that is for hours. It remains sustained for hours. What is the reason for the phase 1? The reason for phase 1 is release of the insulin that has been already synthesized and stored in the beta cells. So the moment glucose increases, the stored insulin is immediately coming into play to bring down the blood glucose level. After that, what happens? There is a slight drop and then again it reaches a plateau and it keeps maintained at that level. That is the phase 2. Okay, what is the reason for this phase 2 of this insulin response? Phase 2 is because of synthesis of new insulin and then further secretion of the newly synthesized insulin. That is why it doesn't happen within minutes. It takes at least a minimum of 30 to 60 minutes to reach phase 2, because new insulin has to be synthesized and then secreted. Okay, so whenever glucose is given, what do you see? Biphasic insulin secretion. Another important point what I want to add here, in patients of type 2 diabetes mellitus, it is the phase 1 that is affected. The phase 1 of insulin secretion is affected. So that is why these patients have postprandial hyperglycemia. So next time if they ask you a question, what is the cause of postprandial hyperglycemia in type 2 diabetic patients? What is the reason? It is because in type 2 diabetics, the phase 1 of insulin secretion is affected. That is why. Okay. So what is the right answer here? Option D. Rise first and then remain continuously elevated. Going on to the next question. In a 28-day cycle, what hormone levels are seen between day 21 to 25? That is during the mid-luteal phase. How will the hormone profile look? That is what they are asking. Okay. For that, let us look at this diagram, which is showing us the hormone levels during menstrual cycle. 4 important hormones that play a role in menstrual cycle, we all know: FSH, LH, progesterone and estrogen. So in the x-axis you have the days, okay, and then we are looking at the different hormones. So from day 1 to day 14, what do we call it as? We call it as follicular phase. What is the other name for this phase? Follicular or proliferative phase, right? Around day 14, what do we call it as? Ovulatory phase. And then from 14 to 28, what do you call it as? We call it as luteal phase or secretory phase. Secretory phase or luteal phase, right? So now, what are all the hormones that plays a role during this follicular phase? Let's see at that first. If you see among these 4, can you tell me by looking at it, or can you please identify which color line is first to increase? So we have 4 colors, right? Orange, green, purple and blue. Among these 4 colors, which is the first to rise? Yes, you're right, it is the blue. So the first hormone to rise is your FSH. Okay, when does it happen? It happens during the follicular phase of the menstrual cycle. So in your menstrual cycle, during the follicular phase, the first hormone to increase is the FSH, and this makes sense. Why this FSH increases? For growth, to potentiate the growth of the ovarian follicle. Okay, so in response to this FSH, now what will happen? The ovarian follicles will grow. As the ovarian follicles grow, what will happen? What is secreted from this follicle? Yes, you're right, estrogen. So now can you see, following this blue line, which is the second colored line which is rising? Yes, it is the purple one, that is the estrogen. So the second hormone to rise is estrogen. Okay, from where is it secreted? From the ovarian follicular cells, estrogen is secreted. This estrogen, so second hormone to rise is estrogen. Now what is the role of this estrogen? It causes the proliferation of the endometrium. That is why it is also called as proliferative phase. So it causes the proliferative of the endometrium. So that is with respect to estrogen. Okay, then around day 14, what is happening? Third hormone to rise. Can you see this green color? What is this? LH or luteinizing hormone. So the third hormone to rise in the menstrual cycle is around ovulation, day 14, LH increases. Okay, this is called as LH surge. Why this happens? So that ovulation happens. So the Graafian follicle releases the mature ovum. So this is happening for proliferation of endometrium. So for proliferation of endometrium only, estrogen is increasing. Then LH is for ovulation. Okay, then finally, which is the last hormone to rise in our menstrual cycle? The last hormone to rise is this orange one, that is progesterone. What happens following ovulation? The Graafian follicle will now get converted to corpus luteum, and the corpus luteum secretes progesterone. Why does it secretes progesterone? Prepares the endometrium for implantation. So it prepares the endometrium for implantation, so the progesterone rises. So what is the order? Many times they can even ask you the order of rise of the hormone. The first hormone to rise in the menstrual cycle is follicle stimulating hormone, following which the second hormone to rise is estrogen. Following estrogen, the third hormone to rise is luteinizing hormone, and the last hormone to rise is the progesterone. Okay. Now our question was around day 21 to 24. So somewhere here in the mid-luteal phase, 21 to 24 or 25. During this mid-luteal phase, how are the hormones looking? Look here and see. What can you observe here? Progesterone is raised. Estrogen is also increased, whereas LH and FSH are at the baseline. Okay, why LH and FSH are at the baseline? Because the increased progesterone estrogen has a negative feedback effect. That is why LH and FSH are suppressed. Okay, so with this, Let's go back and see the option. Look for that option where estrogen is increased, progesterone is increased, LH and FSH are low. That is option D. So the right answer here is option D. Okay, next. Which among the following hormone in a lactating mother is responsible for the growth of breast tissue? So they've given 4 hormones. They're asking which hormone is important for the growth of breast tissue. When do we call growth of breast tissue? Means they are referring to growth of the ductal tissue. Okay. And which hormone causes the ductal tissue growth and enlargement in the breast size? It is estrogen. Okay, it's a direct question. So estrogen is responsible for the growth of breast tissue. Then what about the other hormone? What is the role of oxytocin? Oxytocin is for milk ejection. Okay. What about prolactin? Prolactin is for milk secretion. That is lactogenesis. Okay. What about progesterone? Progesterone is for growth of alveoli and lobules. Okay. Be very clear. Oxytocin is for milk ejection, prolactin is for milk secretion, progesterone is for lobulo-alveolar growth, estrogen is for growth of the ductal tissue, which means growth of the increase in the size of the breast tissue. Okay, clear all of you? This is a pretty direct question. So now we have the next question. So here they have given the Starling forces and they have asked you to calculate the hydrostatic pressure in the interstitium. Okay. So here P stands for the hydrostatic pressure and pi stands for the oncotic pressure. Okay. Now what are these Starling forces? Starling forces are nothing but these are the forces that governs the fluid movement across the capillaries. Okay. So these fluid movement across the capillary is governed by only 2 forces. What are those? Hydrostatic pressure and oncotic pressure. Hydrostatic pressure favors filtration. Oncotic pressure opposes filtration. Okay. Now we can see PC. What do we mean by PC? PC means it is the capillary hydrostatic pressure. Okay. C stands for capillary. P stands for hydrostatic pressure. Okay. So hydrostatic pressure in the capillary is represented by PC. Okay. Then they have asked you to calculate the hydrostatic pressure in the interstitium. Now what does pi stands for? Pi stands for oncotic pressure. Okay. So pi C means what? Oncotic pressure in the capillary. And pi I is oncotic pressure in the interstitium. Okay. So we have all these 4. Now how can you calculate the net filtration fraction? Using this forces. It is given by the formula PC plus pi I minus Pi plus pi C. Basically what have they done? They have grouped all the forces that favor filtration and they have grouped all the forces that favor that oppose filtration. Okay. So the capillary hydrostatic pressure and the interstitial oncotic pressure favors filtration and the vice versa you can see here. When you substitute the values in this formula, okay, they have already given these values. So when you substitute the values in the formula, automatically the interstitial pressure what you are getting is around minus 2 mmHg. Okay, why we have put the net filtration pressure as 0 here? Because at equilibrium the net filtration pressure is 0. Okay, I hope it is clear. It is very simple. All you have to do is in the formula add the values at their appropriate places. Automatically you will get the answer. Now next question. By what mechanism does hydrochlorothiazide prevent calcium stone? What is this hydrochlorothiazide? It is a thiazide diuretic. Okay, it is a thiazide diuretic. What they are asking is how does this diuretic agent prevent the formation of calcium stone? So before going into the options, let us just look at the sites of action of different classes of diuretics, because many questions have been asked from these topics repeatedly. So let us first start with the PCT. At the level of proximal convoluted tubule, you have 2 drugs that is acting. Okay, one is a carbonic anhydrase inhibitor. like acetazolamide. Okay, drugs like acetazolamide, which is a carbonic anhydrase inhibitor, acts at the level of the proximal convoluted tubule. How do they act? It increases the excretion of sodium bicarbonate, so it makes the urine alkaline. Okay, then what is the next drug which acts at the level of PCT? An osmotic diuretic like mannitol. An osmotic diuretic like mannitol also acts at the level of proximal convoluted tubule. It is an osmotically active agent. So whenever mannitol is there in the lumen, it is going to draw water along with it. So it helps in diuresis. So two agents acting at the level of PCT. What are those two agents that acts at the level of PCT? One is a carbonic anhydrase inhibitor like acetazolamide. The second is an osmotic diuretic like mannitol. Mannitol even acts up to the level of the thin ascending limb of loop of Henle. After that, what do you have? The thick ascending limb of loop of Henle. Okay, then we have the thick ascending limb of loop of Henle. Okay, drugs which acts on the loop of Henle are called as loop diuretics. That is why they are called as loop diuretics. Okay, so what is the example of, can you remember any example of loop diuretic? Yes, furosemide, right? So drugs like furosemide act at the level of the thick ascending limb of loop of Henle. What does it do? It basically acts by blocking the sodium potassium 2 chloride co-transporter. Okay, it blocks the sodium potassium 2 chloride co-transporter. Because of this, what will happen? It causes increased excretion of sodium, potassium and chloride, thus bringing about diuresis. Then following the thick ascending limb of loop of Henle, then what is the segment? The DCT, that is the distal convoluted tubule. Specifically, if you have to say early DCT, at the level of early DCT, thiazide diuretics. The question in our question, we have thiazide diuretics, right? How do these thiazide diuretics act? They act by blocking the sodium chloride symporter. So they block the sodium chloride symporter, thereby increasing the sodium chloride excretion. So thiazide diuretics acts at the level of DCT. What do? They increase the sodium chloride excretion and simultaneously they increase the reabsorption of calcium from DCT. Okay, so it increases the sodium chloride excretion and calcium reabsorption. So when more calcium is reabsorbed, less calcium in the urine, so less urinary stone formation. That is how thiazide diuretics prevent urinary calculi formation. That is our question. Finally, we have the collecting duct. At the collecting duct, what is the agent that is acting? Aldosterone antagonist. Okay, aldosterone receptor antagonist. These are also called as potassium sparing diuretics. Another name for this diuretic is potassium sparing diuretic. Any example? Spironolactone. Okay, so diuretics like spironolactone, also called as potassium sparing diuretics, they act at the level of the collecting duct. They increase the sodium excretion and they retain potassium. That is why they are also called as potassium sparing diuretic. Another type of diuretics also act at this level. They are called as ENaC blockers. Okay, they also act at the level of collecting duct. So now we have discussed in detail different class of diuretics acting at different segment of the nephron and their mechanism of action. And what is the answer here? How does thiazide diuretic prevent stone formation? It increases the calcium reabsorption in the distal tubule. So this is the right answer. Okay, next we have a pedigree here. Okay, so what does this pedigree show? Inheritance pattern shown here, maternal only. So they have given 4 disease condition and they are asking this pedigree matches with which among these 4 disease condition. Okay, what is the striking feature that you see here? The mother is affected and she is transmitting the disease to all her offsprings. Okay, now when you look at these offspring, all the females are further transmitting it to their children, whereas the male does not transmit the disease. So in such a scenario, it is a very, very classical example of what? Mitochondrial inheritance. This is a classical example of, because only the females are transmitting. From the mother, it is going to all their children. From among the children, only the females are further transmitting it to their offspring. So this is an example of mitochondrial inheritance. Okay. Among the 4 options, it is option C. Kearns-Sayre syndrome is the one where such a mitochondrial inheritance pattern is seen. Okay, that is why option C is the right answer. Okay, next question. We have a 15-year-old boy who has had a sudden growth spurt over 2 years. He presents with a height of 6 foot 4 inches. Growth spurt, 6 foot 4 inches, coarse faces and headache. Headache is a very important point here. What is the confirmatory diagnostic test? So first, what is the diagnosis? The diagnosis is gigantism. And what could be the cause of this gigantism? Growth hormone excess due to a pituitary tumor. Why have I written as pituitary tumor? Because he is complaining of headache. So that gives me a clue that this gigantism is due to a pituitary tumor which is producing increased levels of growth hormone, which has led to this gigantism. So this is the diagnosis. Now the question is, what is the confirmatory diagnostic test for gigantism? They have given 4 options. IGF-1 level, growth hormone level, IGF-1 level after OGTT suppressed, growth hormone level after OGTT suppressed. Most of the time it is very tempting to go and select option B, that is growth hormone level. It makes sense, right? The patient is having gigantism and that is also due to increase in growth hormone level. So if I measure growth hormone level, I will be able to confirm my diagnosis. Yes or no? Most of us will think like that, but that is not the right answer. Why that is not the right answer? Because we all know the growth hormone secretion is pulsatile. Growth hormone secretion, very key point. Growth hormone secretion is pulsatile. It is not the same throughout the day. So when we randomly measure growth hormone level, we will not get the accurate growth hormone values. That is one reason. So that is why measuring growth hormone is not appropriate. Okay, then can we measure insulin like growth factor 1 level? Because how does growth hormone exert its action, brings about its action? Through IGF-1 levels, right? Primarily it brings about its action of increasing in the height, this crow's phrases, all those things by upregulating the IGF-1 levels from the liver. So can measurement of IGF levels give us a clue to this condition? Yes, IGF levels can be measured, but that is done for screening, because in patients with growth hormone excess, that is in gigantism, increased IGF levels will be seen, which can be used as a screening tool, not a confirmatory diagnostic test. That leaves us with only 2 options, C or D. Already I told you IGF-1 is only for screening, not for diagnosis. So with that itself we can rule out option C as well. Even with exclusion you can arrive to option D as answer. Okay, now I will tell you why option D is the right answer. In a normal person, when we give a glucose load, when you give an increase glucose load, what will happen? Decrease in growth hormone levels. Why? Because these are counter-regulatory hormones, right? Whenever there is hypoglycemia, growth hormone levels will increase. Growth hormone is hyperglycemic hormone, right? So when there is hypoglycemia, growth hormone levels will increase. Here we are giving a glucose load. We are doing oral glucose tolerance test. So here we are giving a glucose load. When the blood glucose level is increasing, automatically in a normal person, growth hormone levels will reduce. Why growth? Can you think about why growth hormone levels will immediately come down? Because of release of somatostatin and insulin. Because insulin and somatostatin are released, which will bring down their growth hormone levels. Now in people with gigantism, what will happen? Now in people with gigantism, increase in glucose load will fail to suppress growth hormone. Okay, that is why option D is the right answer, and this is the gold standard confirmatory test. Now coming to the next question, we have a patient who came with nausea, vomiting. We have a patient who comes with nausea, vomiting and muscle cramps. Patient presents with hyponatremia and hyperpigmentation. What is the reason for this hyperpigmentation? First, what is the diagnosis here? The diagnosis, Addison's disease. So in Addison's disease, what is happening? There is decreased production of aldosterone, right? So there is decreased production of aldosterone as well as cortisol. Okay, both cortisol level is also decreased, aldosterone level is also decreased. So because of the decrease in aldosterone level, there is hyponatremia. Okay, and because of the decrease in cortisol levels, what happens? Because of the decrease in aldosterone, there is hyponatremia and there will be hyperkalemia, and that hyperkalemia is the reason for this muscle cramps. Now what they are asking us is, what is the reason for this hyperpigmentation? The cause for this hyperpigmentation is mainly because of this decrease in cortisol level. When the cortisol level is decreased, what is happening? Negative feedback inhibition is removed. When the negative feedback inhibition is removed, then what will happen now? More ACTH will be synthesized. Okay, more ACTH will be synthesized. How is this ACTH synthesized? It is synthesized from pro-opiomelanocortin. Okay, so this pro-opiomelanocortin synthesizes ACTH. When it is synthesizing ACTH, it also synthesizes alpha MSH. It is also called as alpha melanocyte stimulating hormone. So once the negative feedback inhibition is removed, what will happen? POMC will start producing more ACTH so that cortisol levels can rise. While forming ACTH, it also forms alpha MSH, and it is mainly this alpha MSH which stimulates the melanocytes, leading to hyperpigmentation. And to a certain extent, ACTH can also directly stimulate the melanocyte to produce hyperpigmentation. In your options, if you have alpha MSH, the first answer should be alpha MSH. Here alpha MSH is not present, so we will go to the next best answer, that is ACTH. So the cause of hyperpigmentation in Addison's disease is mainly the stimulation of melanocytes by ACTH in this scenario. But if you have alpha MSH, that is the right answer. Next question, again in the same line only. A patient presents with muscle cramps, fatigue and salt cravings. What could be the underlying diagnosis? Just now we saw what is the underlying diagnosis? Addison's disease. Okay, salt craving because of hyponatremia, muscle cramps because of hyperkalemia. Okay, fatigue because of decrease in cortisol. Okay, this is because of hyperkalemia. This is because of decrease in cortisol, so he doesn't have any energy. Salt craving is because of hyponatremia. Okay, now coming to the last question. A patient presents with complaints of amenorrhea and galactorrhea. A patient complains presence of amenorrhea and galactorrhea. Investigations revealed a pituitary tumor and high prolactin level. So what is the diagnosis here? Pituitary tumor means, so what is the answer here? The diagnosis is prolactinoma, right? But what is the question? What is the reason for amenorrhea? So they've given us 4 options. Among these 4 options, what they are asking is how prolactinoma causes amenorrhea. When you look at these options individually, low GnRH, high pulsed LH, high FSH, low LH and FSH, all this can cause amenorrhea. All the 4 options can lead to amenorrhea, but we have to find out among these 4 which is the reason prolactinoma is causing amenorrhea. Okay, first let us look at the first option, low GnRH level, that is low gonadotrophin releasing hormone. Okay, so what happens here in prolactinoma? The increased level of prolactin will inhibit, okay, increased prolactin will inhibit the kisspeptin hormone or kisspeptide levels in the hypothalamus. Okay, when the kisspeptide is inhibited, then what will happen? GnRH secretion will decrease. When GnRH secretion decrease or when it gets inhibited, what happens? No or low LH and FSH. When you have no or low LH and FSH, what will happen? it will result in amenorrhea. Okay, so what is the answer? How prolactin brings about amenorrhea? By reducing the level of low GnRH. Okay, how it is reducing the level of GnRH? By decreasing the activity of this kiss peptide. Okay, next, then let us also look at the other option. How high pulsed LH can cause amenorrhea? It is usually seen in PCOS. If it is a patient of PCOS, then you would have selected this option. When do you have high FSH? In case of primary ovarian failure. If the scenario is that of a primary ovarian failure, then you would have selected option C. What about option D? Option D is a consequence of low GnRH. When gonadotropin releasing hormone is low, obviously FSH and LH is going to be low. So that completes our detailed discussion on the questions that has been asked this year. I hope it helps you. All the very best for all your forthcoming examinations. Thank you.